This is nursing care of the child with an alteration in intracranial regulation or a neurologic disorder. So let's start off with differences in anatomy and physiology. On a baby, the first 3 to 4 weeks of gestation, this is where the brain and the spinal cord really are developing. So an infection or trauma, or if the mother exposes that fetus to some kind of a teratogen, or if the mom's malnutrition, all of those things can do damage to the developing central nervous system of the fetus. At birth, the cranial bones are there, but remember they're not fused, which allows the baby to get out, but it also, those bones can override for a little bit. It's why we have the fontanelles, we have the open sutures still. The baby's brain is highly vascular, and this is why some of those potential complications during birth are hemorrhaging and intracranial hemorrhaging. For a child, their spinal cord is still mobile, and so we are even more worried about cerebral spinal injuries. And myelination. Babies are born with the nerves, but the nerves aren't well myelinated in the central nervous system, and so that myelination is happening during infancy and young early childhood, which makes a big difference in the speed and accuracy of nerve impulses, which is why they get much better at being able to control their movements. If you remember, in utero, the head develops more than anything else. It's just sort of looking at proportionally, if you looked at how big the baby's head is compared to its body, compared to a child, compared to an adult, you just see how big the head is comparatively. So when we are worried about a neurologic disease, we want to ask about things like prematurity, high risk for those preterm babies of having bleeding, intraventricular hemorrhage. If it was a difficult birth, again, that risk of bleeding in the brain. If there's any infection during pregnancy, if they've had a fall or a trauma. So some of the signs and symptoms that go along with a neurologic disease, similar to what you're used to, things that cause increased intracranial pressure cause nausea, vomiting, and headaches. The pressure on the different parts of the brain cause changes in gait, loss of motor function, visual disturbances, level of consciousness or confusion. And I should have underlined that. That is our first and best assessment piece, that there's a problem, a neurologic problem. So increased irritability. On infants, you'll hear the mother say, I can't console them. Everything, the rocking, the bouncing, whatever they usually like isn't working. They're unconsolable. That increased irritability. And then alteration in muscle tone. So those are all signs and symptoms. So some of the procedures we're going to do, a ventricular peritoneal shunt, and we'll look at that on the next slide, but it's a shunt that takes the CSF fluid made in the ventricle of the brain, and actually I should be pointing more like this. It's usually about right across from the tragus of the ear, but it takes it out, and just under the skin we've got this little shunt that comes down and just dumps it out into the peritoneum. Big, sterile place that can do lots of absorption. Hyperventilation, if we're worried about swelling, a child's had a head trauma and we're worried about swelling, remember swelling can get worse for 48 to 72 hours. So sometimes we will hyperventilate to lower the CO2, to constrict blood vessels a little bit, to minimize just volume inside the cranium, and try and prevent worsening cerebral edema. A child who's had a neurologic disorder often needs therapy, physical therapy, occupational or speech therapy, to regain skills or to learn skills. externalized ventricular drain, we'll look at that. It's sort of like that VP shunt, except it's external. A ventricular tap, this is especially on a child who's still got open sutures, open fontanelles. They can just puncture with a needle and draw off if there's some sort of an effusion, a little pocket of fluid or something, blood, whatever, that needs to be drained off. Vagal nerve stimulator. This is for intractable seizures. So seizures that haven't responded to other things, they put this little stimulator on the vagal nerve. Ketogenic diet. Again, this works well for some kids, or it helps as an adjunct to their other medications. It's a diet that sometimes gets used for kids to try and help control seizures. So here's the VP shunt. So this is the ventricle down in the center of the brain where the CSF is made. And for whatever reason, there's too much being made, it's not flowing, or it's not absorbing. You should make it. It should bathe the brain and the spinal cord, absorb at the same amount as is being made. For some reason, it's not happening. The ventricles are filling up with that CSF fluid. So we've got to get it off. So this is under the skin, and you can feel it. It runs right behind the ear. And then usually when you get down to the body, you kind of lose it. But again, it's still just under the skin. And then somewhere when you get down into the peritoneum, so somewhere below the diaphragm, it just goes deep and then dumps out that extra CSF. They actually leave a whole lot curled in there, so as the child grows, ideally it just kind of stretches out with them. And in a perfect world, you would never have to do anything. Sometimes it gets kinked or it gets clogged, and so sometimes they do need to be revised. Here's our external ventricular drain, and this is exactly what they have at Valley Children's. So this, we have, just like that VP shunt, something going down into the ventricle of the brain, but instead of it staying internal, it comes external, and it comes and it drips into the top of this. And then this fills up. There's a little stopcock you can open and let it dump down into the bag. And so we're able to take off very specific amounts of CSF and measure it very accurately in a closed system. We don't have to open this at all. And then when this bag is full, it's a very sterile thing with a couple of nurses to change out this whole thing. It all comes as one. CSF should be clear and colorless, right? So this is a problem. I can't see through it, and it's very red. So that's probably why they have the external drain. We don't want to just dump this into the peritoneum because we may do irritation, and even worse, we're probably, if we ran that through a VP shunt, it would clog it all up. And that may be what happened, either an infection or trauma, something clogged up the VP shunt. We've still got to get that extra CSF off while we treat the infection or clear up the trauma. And then after this is back to clear and colorless like it should be, then they'll internalize a new shunt. And here's just a picture of that vagal nerve stimulator. So this is somebody who we haven't done well with different medications, or everything we've tried isn't working well. So this can stop them as a seizure starts. It stimulates and stops them. So some of the medications we use, we looked at that externalized drain. Meningitis is always an issue when we're dealing with intracranial issues. So that's treated with antibiotics. Our big concern is bacterial meningitis. That is life-threatening. Anticonvulsants. Benzodiazepines have some anticonvulsant effect. They also have a sedation effect, and sometimes we are using those for seizures, to prevent seizures. Sometimes we're using them to sedate someone to lower the metabolic demand of the brain if we're having trouble perfusing the brain because of cerebral edema. Analgesics. If you have a head trauma or increased intracranial pressure, it hurts. The problem is if we give you really strong narcotic medication, it can make you not breathe well, which will actually raise your CO2. And I was saying sometimes we hyperventilate to lower your CO2. So we don't really want that. It also takes away us being able to gauge, are you getting better or worse? So what we give, it's kind of tricky. The doctor's got to figure that out. We don't want to leave a child in pain. Pain doesn't help you heal. Pain also, you're stressed, and that increased intracranial pressure is going to go up with that. So we do want to keep them comfortable, but we don't want to mask the ability to see changes in their level of consciousness and irritability and comfort and all those things. Osmotic diuretics. Actually, we'll look at that in a moment. And then corticosteroids bring down swelling if there's swelling in the brain. So our osmotic diuretics, the main one is mannitol. And if you remember, this is a big sugar molecule that pulls fluid into the vasculature, into the blood vessels, and then it dumps out in the urine. Mannitol doesn't go into tissue at all. It doesn't do anything except go in and then out in the urine. So kidneys have got to be working, because that's how you get rid of it, is through the urine. And the goal is it pulls fluid, and usually we're trying to treat cerebral edema. We can also use those loop diuretics like furosemide. That just makes you dump, and then because you're a little bit hypovolemic intravascularly, things are going to shift. So it doesn't have that same osmotic pull. At children's they prefer hypertonic solutions over osmotic diuretics. You may occasionally see mannitol, but more often you will see 3% sodium chloride, right? Normal saline is 0.9. So this is more than, 3 times that. And the idea is that extra saline in the bloodstream is going to pull water, right? Remember, water goes where sodium goes. So it's going to pull water into the bloodstream because we're trying to get it out of the tissue in the brain because of cerebral edema. Sedatives, as I said, we use these because they lower the metabolic demand of the brain. And we're having trouble meeting it. But it also, if we sedate you, now we can't really watch for changes of level of consciousness. So that's the doctor having to figure out what's more important. Anticonvulsants. We don't want kids who have had a head trauma to have a seizure because that will increase their intracranial pressure. So we're going to put them on those anticonvulsants as well. A kid who's had a head trauma and we're really worried about their ICP being high, we are likely to paralyze them. Again, we might hyperventilate them if we're trying to control their breathing on a ventilator. They're going to fight us unless we use a paralyzing agent. If need be, sometimes we do a medically induced coma, and this is using barbiturates, and we don't like to, this is kind of a last resort. If nothing else is working, we're worried that swelling's going to keep getting worse for 2 to 3 days, 48 to 72 hours. We're going to put them in that coma, and we really don't know how they're going to do neurologically until after we let them wake up afterwards. Right? And the whole idea of that is decreasing the metabolic need of the brain, because if we've got so much pressure in there that we're not getting good blood flow, we're not getting oxygen and sugar and nutrients to the brain, well, if we can decrease what the brain needs, we can protect the brain a bit. So that's the idea with that.